Welcome to another webinar hosted by WiSH Sport and Health, the research group that oversees some research, clinical and academic functions in sport and exercise medicine at WiSH University. A great pleasure to have you back after a couple of weeks absence to continue this series of WiSH Wednesday talks. And I think today we'll continue the tradition of some of the excellent topics that we've covered over the last few weeks. As always, a big thanks to the sponsor who's seen us through and supported the technical aspects of these webinars through the year, Lita Pharma. We really appreciate the association. We look forward to an ongoing association next year and some really exciting announcements coming regarding our partnership with Lita Pharma. So thank you very much to them for all their support. A great thank you to SASMA as well. We've had a great collaboration with South African Sports Medicine Association through these webinars, and I'm going to be delighted to introduce the president of SASMA, Professor Christa Janse van Rensburg, in a couple of weeks to host one of the webinars which we have been co-hosting for some time. So thank you very much to SASMA for their ongoing support in promoting these as well. As you know, these talks are CPD accredited. So we thank our administrator at WiSH, Nadine Peterson, for all the work she puts in. You'll be directed at the end of this webinar as to how to apply for those points, and they should be forthcoming in the next week or 10 days through your email. So just make sure you put the correct details onto the submission, and then you should receive your certificate fairly soon. So on to the talk for this evening, which is something that's very close to my heart, really for the reason that I always try and promote in my work and in my teaching the collaboration between clinician and radiologist. So we're very fortunate in having a radiologist join us this evening who has expertise and an interest in musculoskeletal radiology and medicine, and who I know really values working very closely with clinicians. And so when one does that, when it has that relationship, the person who gains the most is the patient. So it's really a pleasure to welcome Dr. Peter Mercouris, joining us from Durban, who's going to talk to us on the topic of SLAP lesions and how we image them and how they present clinically and surgically. And it's really a wonderful talk. It's such a wonderful talk, which I'm privileged to have seen before, that it won first prize at the European Society for Musculoskeletal Radiology. They awarded this first prize out of all the presentations given in that particular year. So Peter, that is really a great feather in your cap, and we're really privileged to share this with you, and also to welcome your colleagues from around the country from the South African Musculoskeletal Imaging Group, SAMSIC, who are also great supporters of sports medicine in this country. So I'm going to hand over to Dr. Peter Mercouris, ask him to share his screen and sit back and with the audience enjoy the next hour of this superb talk. Thank you, Peter.
Thank you, John, for that kind introduction and invitation to speak this evening. I have no disclosures, but I do have to admit that when giving lectures at congresses, I rely heavily on the presenter view, but unfortunately this facility is not available on the Zoom platform. So I'd like to apologize at the outset for any slide transitions that aren't as smooth as they should be. I'll be in constant contact with John and Robin in case there are any audio-visual synchronization issues during the presentation. So just some acknowledgements before we commence with the presentation. All the MR images that you see are from my practice's archives. I'd like to thank Neil Northey for the color illustrations that you'll see in this presentation, and those not done by him have been appropriately referenced. And really, I'd like to thank all my orthopedic colleagues in Durban from whom I've learned so much and continue to learn from. And the list of orthopedic surgeons that you see in the slide are those that have contributed to the arthroscopic images that will be presented this evening. So I really need to make special mention of Dr. Sham Osman, who pretty much kick-started my journey in shoulder imaging more than 20 years ago. He arrived in private practice after completing a shoulder fellowship abroad, and I soon realized that we were not offering a good enough service and that we would have to upskill, and very quickly at that. And I must admit, my MSK journey has been very rewarding, and I must thank my orthopedic colleagues for the luxury of my errors that they afforded me in those early days. And the irony is that the first time I gave this presentation was not at a radiology congress, but at an upper limb orthopedic congress in 2005 at the invitation of Dr. Osman. Anyway, so let's start with the presentation. In the next hour, we're going to be looking at SLAP definition and classification. We are going to look at the diagnostic challenges faced by the clinician, the arthroscopist, and radiologist. We're going to look at very basic MR sequences. We're going to look at the important anatomic variants. We're going to discuss a practical approach to SLAP tears, and then we're going to conclude with some interesting cases. So we know the glenoid labrum is a cuff of fibrocartilage tissue. It surrounds and deepens the glenoid fossa, and it acts as a pressure seal. And it also provides an anchor for the glenohumeral ligaments and the long head of the biceps tendon. So what is a SLAP lesion? Well, it's a tear of the superior labrum centered at the long head of the biceps tendon origin. And the acronym denotes superior labrum anterior posterior relative to the biceps anchor. And this concept was introduced in the early 90s by the Snyder group to describe these superior labral tears based on the arthroscopic appearance and evaluation. And the prevalence, initial studies indicated a prevalence of about 4 to 12%, but more recent studies have indicated a prevalence of about 26%. So these are the original 4 SLAP lesions described by Snyder in the early 90s. A type 1 lesion represents degenerative fraying, which is common in the athlete and aging patient. Type 2 is the most frequent lesion that we see and represents a tear with involvement of the biceps anchor. And a type 3 and type 4 lesion, in actual fact, represent bucket handle lesions with an intact biceps anchor in the type 3 and involvement of the anchor in the type 4. Now, between 1990 and 2000, they added a further 6 types to the classification system. And here we look at a type 5 lesion, which is a SLAP tear that is extended anterior-inferiorly, or the other concept is that it's a Bankart lesion that has in fact extended anterior-superiorly. A type 6 lesion is a flap lesion. A type 7 extends into the middle glenohumeral ligament. A type 8 lesion is posterior-inferior extension of the labral tear. A type 9 is a circumferential tear. And a type 10 is extending into the superior glenohumeral ligament. So what are the diagnostic challenges? There are clinical challenges, there are imaging challenges, and arthroscopic challenges. So we know that the clinical diagnosis is in fact difficult, but the history may give a clue as to the mechanism of injury, such as a Fuchs injury or direct trauma resulting in a compressive injury of the labrum, or a traction injury that may be acute or chronic, as we see in repetitive or cross-body motion activities. Now, clinically, the patient may present with popping, clicking, catching, weakness, stiffness, and instability, and one may encounter shoulder laxity. And there are a whole host of provocative shoulder tests that one can do as listed on the slide. But the reality is that there's no single test that is sensitive or specific enough to determine the presence of a SLAP lesion. And I found this study rather interesting. Not surprisingly, the creator of the test is the only one that seems to achieve close to 100% sensitivity for the test. For example, the O'Brien test achieves a 100% sensitivity for his test, but when evaluated in another study, only a 47% sensitivity could be achieved. So that's food for thought. And the clinical diagnosis is often complicated by associated injuries, which are common. Rotator cuff tears are seen in almost 30% of patients, Bankart lesions in 22% of patients, and chondral injury in about 10% of patients. And this is perhaps why sometimes we are faced with a referral letter like this, where the orthopedic surgeon is actually querying pretty much every structure that we image in the shoulder. So what are the arthroscopic challenges? We know that arthroscopy is the gold standard, but it is in fact an imperfect gold standard. And several studies have attempted to validate the arthroscopic Snyder classification, but these have only shown low to moderate reproducibility. These are 3 such studies, but we will briefly look at the first study to give us an insight into the challenges that the arthroscopist faces. So in this study, 73 surgeons were involved. They were each sent 22 video clips, and the clip was about 15 seconds long. And they were asked to do 2 things: determine the type of SLAP lesion and the treatment. And they were resent the same video clip 12 months later. So we're just looking at the SLAP2 component of the study. So what were the results? 58% correctly diagnosed SLAP2. 22% actually considered it a normal labrum, and another 17% diagnosed a SLAP1 lesion. 54% recommended the correct treatment, and only about half made the correct diagnosis and treatment. And as you can see, as mentioned earlier, there is only moderate inter and intra-observer agreement. And this really, and we're talking about experienced shoulder arthroscopists with regards to the diagnosis and treatment of SLAP tears. So that shows you the difficulty that the arthroscopist faces. It's also important to highlight that there is a high incidence of labral tears in asymptomatic patients, up to 72% in one study. And I guess the take-home message here is to perhaps to avoid over-treatment, and physicians should realize that superior labral tears diagnosed by MRI in the 45 to 60 age group may in fact represent normal age-related findings. And I must admit this is analogous to the hip, and I find pretty much the hip MRs that we do, the incidence of acetabular labral tears is extremely high. It's almost, yeah, we've documented a labral tear, let's move on, let's try to find some pertinent pathology in this patient. So moving on to the imaging challenges, what do we know about MR? Well, we know it's very good at making the diagnosis of a SLAP lesion. It doesn't do as well when it comes to classifying the lesion, with a 66% concurrence rate with arthroscopy. So the radiologist has 2 main challenges. Deciding on the type of MR to do. Does one do a conventional MR, or does one do an orthographic MR or MRA? And then to have a very sound knowledge of the anatomy, specifically the anatomic variants, because these can all resemble SLAP tears, as we'll see shortly. So when we look at MR techniques, we can either, as I mentioned, do a conventional or unenhanced MR, or one can do an MR arthrogram, and one has 2 choices here. One can do a direct MR arthrogram, and this involves the introduction of contrast directly into the glenohumeral joint. And it's not really important how one gets the contrast into the joint. It depends on the preference of the radiologist. One can either approach the joint anteriorly or posteriorly and use ultrasound, fluoroscopy, or CT to guide the injection. I must admit I prefer the anterior approach, and I use fluoroscopy. I think it's easier to keep a sterile field. And also I get objective evidence by injecting a small amount of iodinated contrast to confirm that I'm in the joint. And the other approach is an indirect arthrogram, whereby it's based on the premise that there's a joint effusion. You give intravenous contrast and you exercise the joint for 15 minutes and you get an arthrographic effect. I think I've done this once in my 20 odd years of MSK imaging, and I haven't found it useful at all. So when we line the modalities up against each other, and you'll see the fourth modality is CT arthrography. I must admit, we've only done a handful of cases, and really this is limited to patients that are perhaps extremely claustrophobic and refuse to enter an MR unit, or there's an absolute contraindication to doing an MR study. And you can see, yes, there are possibly some outlier studies, but there's no doubt that direct MR arthrography has the highest sensitivity and specificity for diagnosing slab tear. Well, you may ask, well, what about 3T? Is an arthrogram necessary? And the short answer is yes, because the sensitivity is higher with an arthrogram or contrast than without an arthrogram. So how do we triage our patients? And this will obviously vary from center to center. So if we get a shopping basket request, we do a conventional MR. If the clinical question is rotator cuff pathology, we do a conventional MR. And if the concern is of labroligamentous pathology or instability, we do an MR arthrogram. But if the patient is less than 2 to 3 weeks post-injury, we will probably do a conventional MR because they invariably have a large joint effusion if there has been a significant injury. So how do we make the diagnosis of a labral tear? And it's much like the meniscus. We look for two direct signs. We look for abnormal morphology, and we look for intralabral signal, be it contrast of fluid, depending on whether you've done an arthrogram or not, and an important secondary sign, a paralabral cyst. So we'll recap on that a little bit later. So just a crash course on MR sequences, because you're going to see all these acronyms appearing, and I don't want to insult anybody. This is really basic stuff. We know that a T1 weighted sequence is good for showing anatomy. T2 is good for showing pathology because it's fluid sensitive. And a proton density weighted sequence is a kind of in-between sequence. And now the physicists were very clever, and what they did is they took these sequences and they did what's called fat suppression. So basically what it does, it removes the signal from fat, and fat has bright signal. And as you can see here, the marrow is bright, and with fat suppression, the marrow signal is removed, including in Hoffa's fat pad. And what this does, and that you can apply to pretty much any sequence, it makes the fluid more conspicuous, as you can see in this knee where there's fluid adjacent to the anterior horn of the lateral meniscus. Now, as a musculoskeletal radiologist, if you were only allowed one sequence and you were doing conventional MR, you would select the fat suppressed proton density sequence, also known as FSPD or FAT-SAT PD. And the reason is that it's considered the musculoskeletal workhorse, because you can see here, you can see that this is a fat suppressed sequence. The signal in the marrow is gone, but you can see subtle bone marrow edema or bone contusion in the medial tibial condyle. It's showing you the articular cartilage beautifully. And here you can see the nice triangular meniscus, and a labrum would look similar, nice and dark. And you can actually see the ligaments and tendons and any fluid collections beautifully on the sequence. So when we introduce gadolinium, and I really don't want to get bogged down with the physics because I don't think I understand it too well, the gadolinium or the contrast has a T1 shortening effect. So really we do virtually all of the imaging with T1, and we do T1 suppression. So fat suppression, you can see in this patient, the subcutaneous fat the intermuscular fat planes, they all lose their signal with fat suppression. So this is, you're going to see a lot of this sequence in this presentation as annotated there, FST1 weighted. So when we do conventional MR, we tend to use FSPD or FST2 sequences. When we do MR arthrograms, we tend to do fat suppressed T1 or fat sat T1 sequences. And as mentioned, the bulk of the images that you see will be in this type of sequence. And we always add a T2 sequence to the arthrogram to pick up any native fluid collections. So now we come to the important part of the topic, the anatomy. We're going to look at the labrum and the glenohumeral ligaments, and I just want to get the glenohumeral ligaments out of the way quickly. We know that the labrum provides an anchor for these three ligaments. We have the superior glenohumeral ligament, which you can see there on an axial image, and there you can see it as a low signal. This whole structure, this band-like structure, represents the superior glenohumeral ligament. This is it on the sagittal. This is the coracoid process, which is a useful anterior landmark. And this is the superior glenohumeral ligament. Behind this is the subscapularis tendon. And further behind is the middle glenohumeral ligament, which we'll discuss right now. So this is the most variable of ligaments. And you can see on the very left image, there's no ligament present. And you can get a very variable appearance from a thin ligament to a thick and cord-like ligament. And here, as mentioned earlier, on the sagittal, you can see the middle glenohumeral ligament, fairly thin a ligament, and a thicker ligament in another patient. Now, this is the important ligament when one is looking at stability of the shoulder, the inferior glenohumeral ligament, and you can see it on the axial image, the coronal image. You can see the anterior and posterior bands on the sagittal image, this whole structure here. And then you can also see it on the ABBA sequence, which I'll discuss shortly. So when we image the patient, we do the three orthogonal planes, in other words, coronal, sagittal, and axial. But we always add an ABBA view, the abduction, external rotation sequence. As you can see on the left, that's a true ABBA position, and we modify it slightly when we do MR just to get the patient into the coil, into the magnet, sorry. And here is the coil. So what are we hoping to achieve with the ABBA sequence? And I think these illustrations help us understand the sequence. So in the anatomical position, the inferior glenohumeral ligament is lax. And when we go into the ABBA position, we pull the ligament taut. And when we look at corresponding MR images, you can see the ligament is nice and lax. And when you put the patient in the ABBA position, you have created a nice taut ligament. You can see it's attached to the humerus, and you can see this taut ligament and a nice junction with the labrum. This is the inferior glenohumeral labral ligamentous complex. And here you can see if there are any subtle Bankart lesions which maybe don't disclose themselves on a conventional axial image due to the presence of perhaps granulation tissue. And this is the area of the so-called Hagel lesion, where there is humeral avulsion of the glenohumeral ligament. So as mentioned, the ABBA view is actually an oblique axial image. So on the sagittal plane, again, the coracoid process is an anterior landmark. This is the glenoid process. So the ABBA images actually go through the shoulder from a posterior superior to an anterior inferior direction. So in the same image, you'll see a posterior superior and an anterior inferior structure. So why do we do the sequence? Four things that we should look at. So the first thing we need to look at is the integrity of the glenohumeral ligament, which we have already discussed. The ligament is nice and taut. The second thing we look at is the undersurface of the rotator cuff. This structure here, this arc that you see, this is obviously contrast. This is the undersurface or articular surface of the of the supraspinatus tendon, and the tendon footprint is from there to there. You can see it. So this is where you'll see subtle tears of the undersurface of the rotator cuff. The third thing we look at the posterior superior labrum, and this is a good area to look for posterior superior impingement and overhead activities. And then, of course, we look to see if the alignment of the joint is normal. You may pick up subtle subluxation. And just important to note with this sequence or position is patients that are referred for instability. Some patients actually cannot put their shoulder into this position because they fear that the shoulder is going to pop out. So then in those situations, we don't do the sequence. So the glenoid labrum, we've discussed the ligaments. Now moving on to the labrum. It's a challenging structure to evaluate. There's extensive variation with regards to its presence or absence, its signal intensity, and its morphology, specifically the shape and the attachment to the glenoid, which we'll discuss now. So before we do that, just from a nomenclature point of view, you can either divide the labrum into 6 quadrants or use a clock zone methodology to describe lesions. And 3 o'clock, I know this is at odds with the arthroscopist, 3 o'clock refers to the anterior labrum in both shoulders. It's not really important which system you use as long as you and the referring clinician are on the same page. So for example, with the quadrant nomenclature, you have a superior, inferior quadrant, anterior, superior, anterior, inferior, and posterior, superior, and posterior, inferior. So for example, if you have a tear in this area here, you could say there is a tear of the anterior superior labrum, or you can say there's a tear at the 2 o'clock position. So when we look at the anatomy, we've mentioned we can look at the signal intensity, the labral shape and attachment, and a very important aspect of the talk, the anatomic variants. Again, to highlight, the reason we need to know these variants is they can all masquerade as tears. So for practical purposes, the labrum is of low signal, and that means it's black. But signal variations have been described, but there's no specific correlation with histology. So you can see high signal. It can be due to the so-called magic angle effect, and I'm not sure if you've heard of this before, but in essence, if any structure is at 55 degrees to the magnetic field, what that can result in is a spurious increase in signal intensity that can masquerade as pathology, and this happens in the supraspinatus tendon and in the peroneal tendons. It can be a normal variant, this high signal. We may see it in older individuals. It may represent early degeneration, and it may relate to previous trauma. But the take-home message here is that the labrum should be low signal or black for practical purposes. Then we look at the shape of the labrum. On axial images, about half of the labrum should be triangular in shape, but you've got a whole host of shapes. So we've mentioned you have a triangular shape, and you can see here that the labrum is black, and this intermediate signal, that's the glenoid cartilage that you can see. You can have a round labrum, and you can see at the back here, this patient has missing labral tissue, in fact, has a posterior labral tear. You can have a flat labrum, and you can even have a notched labrum due to the attachment of the middle glenohumeral ligament. So if we line them all up together, just to summarize the shapes, you can have triangular, which is the most common. You can have a flat, you can have a crescent, you can have a round shape, and even a notched shape. So we've looked at the shape, now we're looking at the attachment, and there are 2 types. The type A, where the labrum is attached peripherally with a central free edge. And what this means is that you can imagine contrast gets in under the labral tissue between the labrum and the cartilage, as you can see, and there's very subtle evidence of contrast going between the labrum, which is black, and this intermediate signal, which is the cartilage. And this is the correlative arthroscopy image where you can see there is loose attachment of the labrum. Now, the type B is the easier one to interpret because there is firm attachment of the labrum to the cartilage, both peripherally and centrally, as you can see in this example. So now we're moving closer to the variance. A useful landmark again is the coracoid process because it defines the glenoid equator, as you can see in this patient, the black line. And below this black line, there is firm attachment of the labrum, whereas above this line, there is more variable attachment of the labrum. And there are, in fact, three types of attachment of what we term the biceps labral complex, which refers to the structure here. So the three types are lined up, and basically there is a firm attachment and then progressively a looser attachment. And we'll look at these with corresponding MR images. Excuse me, just to add some water. So again, as mentioned, this is the fat-suppressed T1 coronal arthrogram image, and you can clearly see that there is firm attachment of the black labrum to the cartilage, and there's no recess present in this patient. When we look at the type 2, there is a small recess, a little bit of contrast creeping in between the labrum and the cartilage. And a type 3 is what we term a meniscoid. You can imagine if you flip this around 90 degrees, it looks like the meniscus in the knee. And you can see there is contrast going in and a generous appearing labrum that looks like a meniscus. So here we come to what I term the big five. These are the ones that every single radiologist needs to know about to avoid getting into trouble and over-diagnosing slap tears. So these are the five variants that we'll go through: the sublabral recess or sulcus, the sublabral hole or foramen, the Buford complex, the pseudo-slap lesion, and the high attachment of the inferior glenohumeral ligament. And these all exist, as mentioned, in this quadrant up here. So just to recap, you saw the slide earlier. What do we look for to make the diagnosis of a tear? We look for abnormal morphology, and we look for intralabral contrast or fluid, depending on whether we've done an arthrogram or not, and we look for the helpful sign of a paralabral cyst. So the first variant is a sublabral recess, seen in about 3/4 of cadaver patients, and it's seen at the 11 to 1 o'clock position where there is loose attachment of the labrum. And this represents the type 2 or 3 biceps labral complex attachment that we've just described. And I like to refer to this as the king of the jungle when it comes to variance, because this is the one that gives us the biggest headache when it comes to differentiating from a slap tear. So one cannot discuss the sublabral recess without mentioning the De Palma study. And this was a cadaver study in the late 40s. And basically, they found no recesses in fetuses and infants, but progressively as the patients got older, there was more likely to be a recess present. And in fact, 95% of cadavers over the age of 70 had a recess present. So this is considered to represent some kind of age-related degenerative phenomenon, but it's really unclear as to when this normal labral separation occurs, but there is agreement that this loose attachment may progress to physiological separation or pathological separation, in other words, a slap tear, and the distinction is not always possible, unfortunately. But just to throw a cat amongst the pigeons, a more recent study showed that, in fact, recesses were seen in fetuses over the age of 22 weeks. So what does a sublabral recess look like? We've already gone through it. There's a nice thin contrast collection between the labral tissue, which is normal, and the cartilage. And you can also see it on axial images. If you do a axial slice through there, you should see labral tissue, cartilage, and labral tissue contrast and cartilage. Here you can see the labral tissue, the bright stuff is the cartilage, and this intermediate stuff is the cartilage. Sorry, labral tissue, contrast, and cartilage. So this was an important study that attempted to identify signs that could differentiate a recess from a tear. So on coronal images, signal intensity that was globular, laterally oriented, and that extended posterior to the biceps anchor were features suggestive of a tear. And the lateral orientation of signal is the most statistically significant sign on coronal imaging. So let's put these findings in a comparative table format. So we've said a recess should be smooth. It should be less than 2.5 millimeters when you do an arthrogram. The contrast is directed medially. There shouldn't be extension posterior to the biceps tendon, and there is no paralabral cyst. So what do you see with a tear? It's going to be globular and irregular. It's more than 2.5 millimeters in size. Lateral orientation of contrast is the most reliable sign. Posterior extension is suggestive but not statistically significant for tear, and you may or may not see a paralabral cyst in these patients. So let's look at illustrations. So with the recess, the contrast points medially, whereas with a tear, it should point laterally. Let's look at an MR. Again, the recess points medially, and in this patient, you can see that there's abnormal morphology, and the contrast is directed laterally as well as medially. This was a tear. I mentioned that a paralabral cyst is an important secondary sign in diagnosing a labral tear, and this was unfortunately a case missed by an inexperienced colleague. When you see a cyst, and these can be small, as in this case, you need to hunt for the labral tear. And this was a case that was done without an arthrogram. And when you look carefully at the superior labrum, there is lateral orientation of signal, which we now know is a reliable sign of a tear. The second variant is a sublabral hole or foramen, seen in about 15% of patients. It's lack of attachment of the labrum at the 1 to 3 o'clock position, and it may coexist with the variant we have just described. So this was a 16-year-old water polo player. This is a case from 16 years ago, when I was starting to get really excited. 17 years ago, I started to really get excited that I was starting to learn something. And you can see these are 4 consecutive axial images and pretty much going from superior to inferior. So what we should be seeing, the red denotes the middle venohumeral ligament, but here the labrum, contrast, cartilage. So that's what we see here. So we've got the ligament, labrum, cartilage, and you can see there's a hole where contrast is going through it. And then slowly, as you come inferiorly, the labrum is reattached and there's no longer a hole. And I was pretty convinced that this was a sublabral hole, but in those days we needed to give slap tear as a potential differential. And this is one of Sham Osman's cases. And I said, Sham, I'm sure it's a sublabral hole, but I can't be 100% certain. Anyway, he took the patient to theater, and I've tried to orientate the illustrations with the arthroscopic portal. BT is biceps tendon, PSL is posterior superior labrum, and you need to look in this area, the anterior superior labrum, where there is loose attachment as he comes around the corner. You can see that he's going to lift the labrum up, and that's a nice demonstration of a sublabral hole, a normal variant. This is another case. This is an elderly patient, similar findings. There's displaced labral tissue with contrast entering the hole. And you can actually see on the sagittal that there is almost malalignment of the labral tissue because this tissue is displaced forward because of the hole, and this is the normal part of the inferior labrum. And this was confirmed at arthroscopy. And of course, this wasn't done for sublabral hole, but the patient had a rotator cuff tear, which we haven't shown. So the Buford complex is the third variant, very uncommon, and basically 2 defining criteria. There's absent anterior superior labrum, and there is a cord-like middle glenohumeral ligament. And here, a more recent case, you can see there's no labral tissue anteriorly. That black area is in fact just the cortical bone. And what you're seeing is a cord-like thick middle glenohumeral ligament on the axial and on the sagittal images. And you can see up there, there is actually missing labral tissue. And here you can see the more inferior part of the labrum, this cord-like structure. And then there's missing labral tissue. And of course, the patient has quite a thick middle glenohumeral ligament. And this patient, you can see posteriorly, if you notice there's contrast going in here between the cartilage and the labral tissue, that's a posterior labral tear. The pseudo-slap lesion is the fourth variant. There's a little sulcus between the long head of the biceps tendon and the superior labrum. It is also referred to as the bicipital labral sulcus, and it can be of variable depth, as we'll see, and of course it can resemble a slap tear. So this is another water polo player, similar age 16, and you can see there's a tiny little sulcus. This was a non-arthrogram study, so it's less conspicuous in these patients. This is a second patient following an arthrogram, and you can see there's a bigger recess, and in the third patient, an even larger recess. And in this second patient, you can see this represents the so-called type 3 attachment. You can see this is a meniscoid labrum, and there is a sublabral recess with contrast going in there. So this is a normal variant. But what this patient has, if you look carefully here, this is articular cartilage, and then suddenly it's missing, and there's a flap of cartilage there. There is chondral delamination. The fourth variant, probably the lesser important, is the anterior band of the inferior glenohumeral ligament. We know that the normal band attaches below the equator, and with a high attachment, it attaches above the equator. So this can exist in several variations, with a small anterior superior labrum, with an absent anterior superior labrum, with a cord-like middle glenohumeral ligament, and it can create the impression of a sublabral hole at arthroscopy, especially if the anterior superior labrum is absent. And David Stoller, who's a world-renowned musculoskeletal radiologist, he's of the opinion that most of the sublabral holes diagnosed by arthroscopists in actual fact represent this high attachment with some variation of the anterior superior labrum rather than being a true sublabral hole of foramen. So this was it's actually a colleague, a musculoskeletal colleague, and what you do to make this diagnosis is you start inferiorly and you follow the anterior band of the inferior glenohumeral ligament, and you can see it on sequential images. It should probably stop there, but you keep going to reach the top of the shoulder and it's still there. And the problem is if you see a lot of labral tissue with intervening signal, you might think that there's actually a tear with granulation tissue in this area. And this was a nice demonstration. Same patient. You can see the black arrow points to the middle glenohumeral ligament, and posteriorly is the anterior band, which attaches high up. It comes all the way up to the top. So what is the importance of these labral variants? Several studies have shown that they predispose to abnormality, in other words, labral tears. It's important to differentiate from true slap lesions so that you don't overdiagnose slap lesions and subject the patient to unnecessary arthroscopic procedures. And repair of the variants may have adverse results. The repair of the Buford is a well-known one because if you repair this, it may result in limited external rotation. So those are the 5 variants. Just to refresh our memories again, we said that when it comes to slap classification, MRI doesn't do as well as when it comes to the diagnosis of slap tears. So the recommendation is we should rather describe rather than classify these lesions. And a practical approach to reporting is to describe the location, the morphology, the extension pattern, and the associated injuries. And now we're going to go through a few cases. So those are the 4 things that we should mention in our report. So location, we've already discussed. If the tear is in the 2 o'clock position, it could also be referred to as an anterior superior labral tear. When we look at morphology, we must mention whether it's non-displaced or displaced. And when we look at displaced, it's either a bucket handle or flap tear. So let's look at non-displaced morphology. So here you can see there is, and this is the case we saw earlier, there is high attachment of the anterior band of the inferior glenohumeral ligament. But if you look at the labrum, it's lost its normal black signal intensity. It's of amorphous signal. And this represents degeneration of the labrum, as you can see on this arthroscopic image. And this is a SLAP1 lesion. And as mentioned earlier in the talk, it's common in athletes and in the elderly. I really enjoy showing this image, and this, as you can see, is one of my digitized image in the early days in the pre-PACS era. I'm really showing up my age here. I used to ask the radiographers or the techs to make an extra set of films from me that I would archive myself and then follow up with the orthopedic surgeons to see what they had found at surgery. So this is a digitized image, but what it does show is the globular contrast that is more than 2.5 millimeters in thickness. It's no longer a nice sliver of contrast. The lateral orientation of signal, which we know is a reliable sign of a tear. And you can see here we have now gone beyond the biceps anchor. There's the biceps tendon coming across. So this posterior extension. So this pretty much ticks all the boxes for a SLAP2 tear. And when I reviewed this, I realized that I'd actually missed the fact that this black blob of signal here, in fact, represented calcification in the supra and infraspinatus tendon. So this is the corresponding arthroscopic image. As we said, the lateral extension is a reliable sign of a tear, and the corresponding arthroscopic image confirming the tear. This is another example. We had seen this earlier where contrast was going both laterally and medially, and again confirmed to represent a tear at arthroscopy. Now, when we look at displaced morphology, we look at bucket handle tears or flap tears. So you can see in this patient there is labral tissue which is still black, but it has kind of fallen away from the biceps tendon, which is this structure here, with contrast creeping in between the labrum and the biceps anchor. And this is a SLAP3 lesion. And here is the corresponding arthroscopic image, and you can see the probe with the bucket handle and displacing the bucket handle forwards. This is a case, also a digitized image, but a nice demonstration how the labral tissue has dropped and has also extended into the biceps anchor. Similar to this, it's gone into the biceps anchor, and this was a SLAP4 lesion confirmed again arthroscopically. Now, the next 2 cases are for the die-hard Liverpool fans out there, and on top of that list, you can see in this patient, there is labral tissue that is displaced and abnormal. And on a sagittal image, you can see this is the coracoid process. Remember, it's an anterior landmark. So this is the biceps anchor here. So this tissue has been displaced forward. And this turned out to be a flap lesion or a type 6 SLAP lesion. Looking at another 6 lesion, you can again see abnormal morphology. The labral tissue is displaced inferiorly and away from the anchor, another nice demonstration of a flap lesion. The next category is extension pattern, and the tear can either extend through the labrum or the glenohumeral ligaments. So when we look at the labrum, it can either extend through the anterior part of the labrum as part of a Bankart lesion. It can extend posterior inferiorly, or it can extend circumferentially, or it can extend into the ligaments, either into the middle or superior glenohumeral ligament. So in this case here, side by side, you can see a sagittal arthrogram. You can see contrast between the labral tissue and the glenoid. So this was a classic SLAP5 lesion, and this is an axial image going through the inferior part of the joint, going through this joint down here. And there, as we mentioned, below the equator, there should always be firm attachment of the labrum. There shouldn't be a variant. And you can see posteriorly, the labrum is firmly attached to the cartilage. And here you can see there is detachment and there was any stripping of the scapular periosteum. So, and this was the corresponding arthroscopic image where you can actually see the detached labrum going all the way to the top where the biceps anchor is. In this case, you can see on the coronal image, clearly there is complex contrast. There's contrast going laterally, going superiorly as well as medially. And when you look at the axial image, there is abnormal contrast entering the labrum. Compare that to here where the labral tissue is black and here it's amorphous. So it's gone posteriorly down the back, a SLAP8 lesion. And this is the corresponding arthroscopic image. Again, I've tried to orientate the illustrations with regards to the arthroscopic portals. And you can see here the anterior superior labrum and posterior superior labrum look angry. And going down the back, there is a detachment of the labrum. These are the same patient showing you the detached labrum. And posteriorly, you can see, sorry, my cursor's disappeared. Going down the back of the labrum, posterior superior to posterior inferior, angry looking labral tissue, confirming a SLAP8 lesion. This is a 29-year-old professional rugby player, and these are 3 spaced axial images going through the top of the joint, the middle of the joint, and the inferior part of the joint. And you can clearly see that there is contrast entering between the labrum and the cartilage. And you can even see here the cartilage doesn't quite look nice and smooth, both anteriorly and posteriorly, and from superior to inferiorly. So this represents a circumferential labral tear, a SLAP9 lesion. And these are the corresponding arthroscopic images where you can see superiorly there is complete detachment of the labrum, anteriorly as well as you go from superior to inferior and from posterior superior to posterior inferior. And this is the, again, the arthroscopic image. We're looking at the video clip, sorry. And you can see the anterior part of the labrum, significant labral pathology with detachment. And we're now going to the posterior part of the labrum. And again, similar findings posteriorly. This is the biceps anchor up here, and the whole labrum is stripped from the glenoid. And I'm happy to say this was repaired by the orthopedic surgeon, and he returned to playing for the Sharks again. When we discussed the De Palma study earlier, we mentioned that it was not always possible to distinguish between physiological and pathological detachment. And these 2 cases highlight the point. On the right, the case that we've just seen. On the left, a 60-year-old patient. And you can see similar appearance, perhaps on the right-hand side, the margins of this detachment are not as crisp as in this patient. Patient went to arthroscopy, and sorry, before we get there, the coronal images, you can see a similar appearance. There is detachment, smooth on the left and not so smooth on the right. We know that this was confirmed to represent a slap tear. The labrum was actually normal at arthroscopy. Obviously, the patient didn't go to surgery for the labral tissue. The patient actually had significant biceps pathology. You can see a markedly frayed biceps tendon. The biceps tendon should be black throughout the course, but you can see here it's of intermediate signal, and there are multiple degenerate cysts along the margins of the intertubercular sulcus. So this patient had biceps impingement. We know that extension can occur into the glenohumeral ligaments. This is a fairly recent case. You can see again abnormal morphology superiorly and confirmed on the axial image with quite significant separation of the labrum from the cartilage. And you can see that the ligament is involved because there's contrast splitting that superior glenohumeral ligament, and you can also see it on the sagittal. And this is a slap 10 lesion, and this was again confirmed at arthroscopy. You can see the labral tear extending into the superior glenohumeral ligament. So associated injuries are the last aspect of the report. One should specifically look at the rotator cuff and the cartilage. There are 3 SLAP2 subtypes. There's a type A, which represents an anterior SLAP lesion, which is also seen in the so-called SLAC lesion, the superior labrum anterior cuff tear. The posterior SLAP, which is typical in throwing athletes, representing the peel-back lesion, and the classic type 2, which extends both anteriorly and posteriorly. And it is probably important to make the distinction because these ones that involve more the posterior part of the labrum, they can result in posterior superior glenohumeral instability that may lead to rotator cuff tears. And this was a semi-professional tennis player with posterior superior impingement. And you can see this is an ABBA view. And on the right-hand side, you can see what a normal cuff should look like. So basically, we mentioned that it should be nice and smooth, this arc, and no contrast should enter the tendon if there is no tear. And clearly you can see here that there is a significant amount of contrast entering this tendon, and this is a cuff tear. And of course, the other structure we look at is the posterior superior labrum, which should be nice and smooth. And you can see this almost has the appearance of the end of a broom. So that was a tear of the labrum with a cuff tear. Here we see another patient with a SLAP 2 tear, and again, the ABBA view. And here there's actually a delaminating tear of the cuff because this part of the cuff should be attached to the footprint here. So what has gone on is a tear and it's now peeling away. And this is the so-called superior labrum anterior cuff lesion. And this is the confirmatory arthroscopy image. You can see the detached labrum superiorly and the tear of the labrum, tear of the supraspinatus tendon. And this is the corresponding video clip. You can see the labral tissue angry looking, both anteriorly and posteriorly, with detachment superiorly. And if we speed it along, we get to the point where we can actually see the tear of the supraspinatus tendon coming into view. This is a patient we had seen earlier with the SLAP tear, and on the coronal image you can appreciate that there is actually missing cartilage here. There should be a nice gray contour along here. There's missing cartilage with contrast entering, and you can see how the MR has underestimated the degree of chondral damage. This is a chondral fracture, and this is so-called slap fracture. So before we get on to the interesting cases, that concludes the SLAP presentation with regards to the anatomy and diagnosis and classification. The take-home pearls are that the clinical diagnosis is difficult. Arthroscopy is an imperfect gold standard. Direct MR arthrography is the modality of choice. Knowledge of anatomic variants is vital because they can all masquerade as tears. We should describe rather than classify these lesions, and we've suggested a practical approach whereby we look at location, morphology, extension, and associated injuries. So I'm just going to move on to some interesting cases. This is a case from many years ago. This is when everything conspires against you. The arthrogram was done by a colleague, and this patient was claustrophobic, so needed intravenous conscious sedation when we put the patient into the MR. And as we put the patient into MR, there was a power failure. This is long before the days of load shedding. So we had to get the patient out. Unfortunately, we've got another center fairly nearby, but the problem is we had to let the patient awaken, and by the time we got there, much of the contrast had already been absorbed. But I'd become fixated with the anterior inferior labrum, trying to decide, was this iatrogenic? Eventually, I decided it was iatrogenic, and I kind of glibly passed this off as a sublabral recess because it looked like it was pointing medially. Anyway, the patient went to surgery, and a tear was found. So when I looked at this more carefully, yes, there is a medial extension, but there's also a funny looking blob of contrast that just doesn't conform to a normal shape. So in retrospect, there was a tear on imaging. So I didn't do too well on that study. This was an interesting study where they were assessing the diagnostic performance of MR arthrography and SLAP lesions. In this case, is directly from that study. And if we apply the principles we've learned this evening, there's contrast, it's directed medially. So, I think sublabral recess is a good diagnosis to make. I would have made the same diagnosis. The patient was taken to theater and a tear was found. So as I mentioned, this is the one that gives us great difficulty, the sublabral recess, or the so-called king of the jungle variants. This is the case that we had seen earlier, the SLAP 8, where you can see contrast going in all sorts of directions. It was called a tear, and it was a tear. Now, from the same study, you can see a similar appearance. This is a non-arthrogram study, and it was reported as a tear, and I would have done the same, but at arthroscopy, it turned out to be normal. And if you line up my case and the article case, they pretty much look similar. So we can have difficulty with making the diagnosis. Now, this case was sent to me for a second opinion. And as you can see, it was called or reported as a sublabral, as a bucket handle tear of the labrum. And I told the orthopedic surgeon, with all due respect, this study is an absolute mess. There's contrast outside of the joint, and what the inexperienced radiologist failed to actually establish is that a lot of air has been introduced into the joint. Yes, little bits of air get in, but there is a copious amount of air. And this structure here was probably misinterpreted as a bucket handle tear. But this represents inadvertent injection of a large amount of air into the joint. So anyway, we ended up repeating the study in our center, and you can see what a beautiful, clean arthrogram should look like. You can actually see the cartilage beautifully in this patient. You can see normal labral tissue, normal glenoid cartilage, and normal labral tissue on either side. And if you juxtapose them, the left was the one done at another center and the one done at our center. And clearly on the coronal images, this so-called bucket handle tear that they thought is actually not there if you do the study properly. And again, you can see exquisite detail of the anatomic structures. This is a case, again, a digitized image. I didn't do too well on this case. I got only 50%. You can see on the sagittal image, there's obviously an anterior superior labral tear, and I got that correct. And I'd been reading a lot in those days, and there was talk that when the tendon imbibes contrast, it's suggestive of the tear. And I thought, well, here's the subscapularis tendon. There's a whole heap of contrast, and here there must be a tear. And reported it as such. And so when I got follow-up, I asked the surgeon, was there a tear of the labrum? Yes, there was. And I said, what about the subscap? Absolutely normal. Then I realized that I'd actually plunged part of the contrast into the subscapularis tendon. And it's actually, if one does a lot of arthrography, it's a very, very firm structure. And I always tell my younger partners is, when you think you're in, just give it one more push and you'll be surprised you end up going through the tendon. Because when we come through and do an arthrogram, we're pretty much targeting this area. So we have to come through the subscap. And what often happens is you get there, and because it's firm, if you notice your needle swerving medially or laterally, you know you found the subscap and it's found that plane. So this was inadvertent tendon injection. And occasionally, an unexpected finding, this patient was referred from an arthrogram. The prior imaging was normal, and you can see there is a undisclosed fracture of the humerus. So I had converted a simple fracture into a compound fracture. And I always like to end with this case. This is a case from 1999. I've been given permission to show these images. And as you can see, there is contrast between the labrum and the cartilage, and on the ABBA view, it doesn't depict that well because this was a digitized image. And it was called a Bankart lesion. And I'm not sure, for whatever reason, I don't know if they believed my report, but there was pressures because he's a professional rugby player. It was the end of the season, the sort of Northern Hemisphere tour. So I think they just strapped him up and told him to push through. And virtually to the date, he comes back 2 years later in about October. And you can see what has actually happened. So from a soft tissue Bankart, it has now become a bony Bankart. So he's basically cleaved off the whole part of the glenoid process here. On the ABBA view as well, you can see the detached bony fragment. And this was repaired. And 6 years later, that same shoulder raised the William Webb Ellis Trophy. So on that note, I conclude my talk and like to thank you for the invitation to speak, and I hope that you found it very useful.
Peter, thank you very, very much. And I know that it may have appeared to be quite a technical talk to many, but I can tell you that people stayed right on until the end there, and the comments coming through are very, very complimentary. So thank you very, very much for the time and effort of this talk that's evolved over what looks like about 20 years. So it really comes through that experience. And again, I'm going to start with the comment that I opened with, is that relationship between radiologist and clinician surgeon is really very, very important. And that just referring to a radiology department for imaging doesn't cut it if you're going to do your patients a favor. You need to establish a relationship, and you need to be able to understand that the specialist you're referring to really, really has an in-depth knowledge of that particular area, and you certainly demonstrate that. So if we can start with a few questions. Now that you've made your allegiances known, we're going to make them a lot trickier than they were going to be, because we've had a few of the Manchester United clinicians submitting questions in the last 10 minutes. Nevertheless, if we look as a radiologist and you have that working relationship with a clinician, what information do you want on that form or on the telephone call that comes through saying image that patient? What makes your job easier working with a clinician like myself when we refer.
Am I on mute or am I on
No,
mute?
you're fine.
Can you hear me?
Yeah.
It's basically, we want to know what is the clinical question that you want us to answer. And I think if we know the clinical question, we can then direct the examination appropriately. So that to me is paramount. What do you want to know so that we can answer it? And as we've shown with shoulders, with knees, it's less of an issue. In shoulders, we've got to decide what we're going to do. Are we going to do it in the conventional way, or are we going to do an arthrogram? And as mentioned, we triage the patients. Whenever we're looking for labral ligamentous pathology, we will do an arthrogram, whereas the other rotator cuff issues and the shopping basket, we'll tend to do conventional MR.
So it actually affects your technique and the sort of method of the imaging as much as it does your interpretation.
Correct, correct.
We have quite a few registrars who are on the webinar from the WiSH circuit and from some of the other universities. And could you just talk them through your imaging approach when you have images of a shoulder in front of you? What is the systematic approach that you take to reporting on a shoulder?
So, and this is something I tell the younger partners in my group, the radiology is exciting, but the business of radiology reporting is actually boring because you've got to do the same thing over and over. And by doing that, you're less likely to miss something. So, so I like to look at when I look at any basic MSK image, I like to look at the osteochondral elements first, the osteostructures, the chondral structures. Then, for example, in the shoulder, I will then look at the labrum and the ligaments, and then I'll move on to the rotator cuff and the biceps labral complex, and then I will move on to the adjacent soft tissues and the neurovascular bundles. So I do it in a systematic way. How you do it is not important. You need to find the methodology that works for you. And you just need to find the groove and do that repeatedly so that you don't miss things.
I think that's very sound advice. I'll roll these two questions into one. What is the sort of differential diagnosis? And I think you did answer that, but it'll be good to reinforce it. The sort of differential diagnosis that you will come to with SLAP imaging most commonly, and what are the most common associated injuries that you usually find with a SLAP lesion? So
yeah, so the one that gives us the biggest headache is the sublabral recess, and that one, as you can see, can be challenging. You know, the modality is only as good as the modality, and it's not 100% sensitive, so we are going to get it wrong, but I think one needs to apply those principles that are accepted internationally as to what a sublabral recess is, and accept that occasionally you are going to be incorrect. And then the associated injuries, I tend to find that rotator cuff tears and chondral damage adjacent to a labral injury. Those are the common associations that I see. Extension into the glenohumeral ligaments is in my sort of experience, fairly rare.
Super. Question from Dr. Amaresh Ranchod, who has an interest in musculoskeletal imaging. He's asking, when you do your MR arthrogram, do you do both pre and post arthrogram imaging, or only the post arthro sequences?
No, only the post arthro sequences. We're just too busy to be able to do that. I can tell you the one advantage of not doing an arthrogram is you see the natural soft tissue changes that you'll lose once you do an arthrogram. Because remember, once you do an arthrogram, you're sticking a needle in, there's a little bit of contrast that extravasates outside of the capsule. So natural fluid changes you'll not see on an arthrogram. So that's the one benefit. And a lot of centers, especially the high-end centers, tend to do them without arthrograms now. But having said that, if they looking for labral ligamentous pathology in a high-level athlete, they will do an arthrogram because the sensitivity is better than without.
So there is an advantage to doing maybe a limited sequence pre-arthrogram, but the time
Correct.
consumption and the practicality is really just
not practical at all. Not in private practice where patients are, want to be seen at their appointment time. It would be great to be able to do that, but it's not practical.
Now, in your presentation, you showed both examples of overuse, mostly overhead athletes, and traumatic athletes, the John Smith cases, etc. What are the different patterns you see in each of those in terms of your classification of SLAPs, or do both cross the full spectrum?
No, both cross the full spectrum. And I must admit, Bankart has always kind of been associated with dislocations, but I must admit I've seen a lot of Bankart lesions that are actually just due to repetitive microtrauma. And you can imagine somebody like John Smith, who's a prop. He's always an abduction and external rotation when he's binding with a big prop on either side. So there's that repetitive microtrauma that the labrum is subjected to, resulting in a Bankart lesion without actually having a distinct dislocation injury. So that answers the question, I think.
So it doesn't really narrow it down if a guy is, for instance, a pitcher or a water polo player as opposed to a rugby player.
No.
You still got to really have your eyes wide open for the full spectrum.
Correct.
And then what about age in terms of the younger athlete versus the sort of mature athlete whose growth plates have closed versus the older senior sort of masters athlete? Is there any pattern there in terms of type of injury?
No, I must admit in the younger population, I've tended to see more posterior labral tears, and I haven't been able to answer that. Posterior labral tears are often associated with glenoid hypoplasia, but in these, and that's an easy diagnosis to make, but in a lot of these youngsters that are playing rugby at schoolboy level and they're big, strong athletes, I've seen posterior labral tears and significant ones without glenoid hypoplasia. But I haven't been able to find an answer as to why that association is present.
And just one more question from one of the registrars, just asked if you could talk through your injection approach, your favorite injection approach for the arthrogram. Again, you mentioned a couple.
Yeah, so normally what I do is I do it under fluoroscopy. So what I do is, remember that the glenoid process is at 30 degrees. So what I do is I elevate the opposite shoulder, put a little wedge under the patient so that I see the glenohumeral joint in profile. And under sterile conditions, I inject some local and I go straight down onto the humeral head, the inferior medial humeral head. And what I tend to do first, and I suggest that to the colleagues in my practice, I don't inject the gadolinium. What I do is I inject a small amount of iodinated contrast first, and I make certain that I'm in the joint. And once I'm in the joint, then I change over and put the normal mixture, which contains the gadolinium, contains the local, and the iodinated contrast. And what I find is that it makes for a very clean injection when you look at it at MR. There's no contrast all over the place. So I use an anterior approach. My target is the inferior part of the humeral head. And I inject a little bit of contrast first, iodinated contrast, and then I use the normal mixture, which is about a 20 cc solution. And some people tend to, I would rather over distend than under distend the capsule, so I will give a minimum of 15 cc's. Some people prefer to do less, but I feel that if you're going to distend the joint, distend it properly. So you've got to find a technique that you're comfortable with, basically. Some people prefer to do ultrasound. I find that it's probably easier to keep a sterile technique with fluoroscopy, and also you've got objective evidence that you were in the joint. And if you get good enough, you hardly have to actually screen. You just need to be mindful of that.
Peter, again, all I can say is thank you for a superb talk, a great privilege to witness a talk really of world class and of interest to radiologists, clinicians, those of us that have been in practice for a long time and those that are learning. So thank you very much for all you've done for sports imaging. I think it's a field that's evolved hugely in South Africa over the years, thanks to you and your SAMSIC colleagues. Thanks for your time this evening and for your preparation. And we really do hope that we can call on you at some time in the future again for another excellent talk. Thanks very much.
Have a good evening. Cheers.
Great, thank you. We're going to switch over to a slide which Robin will put up to show our next talk, which I think is going to be another fascinating talk. Again, thank you very much to our sponsors, the Lita Pharmaceutical Group, manufacturers of Zepho, and we're going to be again co-hosting this with SASMA, and we look forward to being joined by Professor Christa Janse van Rensburg, who will help us to introduce this wonderful ethics talk, an actual video of the behind the scenes of the USA gymnastics scandal. Those of you that joined us last month for the ethics talk, where we had 2 world experts talking around these issues, will find this really complementary in terms of the information you glean, and it's a great opportunity to gather some ethics points. So we'll leave this up for a while. You can go to that link for the CPD points and you will be led to that when you log out this evening. Again, thank you to Robin Saggers, who's been very quiet this evening, but very much in the background running the show. I always appreciate what he does for WiSH. Thank you to all of our WiSH colleagues and to those of you who joined us this evening. And again, to Dr. Peter Mercouris. We look forward to all of you joining us next Wednesday, the 25th at 6 o'clock this time for a showing of the Heart of Gold and some insight into some very, very significant and serious ethical issues in sport. So a very good evening to you all from WiSH. Thank you.